Thank you. Seeing no other questions, I have a comment I'd like to make, and then I think it'll lead to a question. First of all, I'd like to take the opportunity for all of you who came up this afternoon to testify on behalf of the various groups you represent. Sorry to see that one of the young lady had to leave, assuming she had, we'll get to her medical appointment. Yes, I agree that we need to look at data. Data is extremely important, whether it's data in the Department of Managed Healthcare, data at DHCS, Department of Health. And yes, it's very important that we have disaggregated data, especially amongst the API community, to look at the different subgroups. And very important how we collect the data, but it's also what do we do with the data? And more importantly, and these are the questions I'm going to ask the administration, is where do we house the data and who is responsible for that data, okay? We have a lot of problems dealing with vulnerable communities, distribution problem, lack of diversity among our workforce. We need to make sure that there's a diverse workforce that's culturally sensitive to those particular communities and unique to those particular communities, and get more providers in there. Another part of it is the rates, increasing the rates to make sure that we get providers to take these patients, the most vulnerable population. But I think what we now need to start looking at, and this is the question I'm going to pose to you and the challenge I'm going to pose to you, yes, that needs to get done. That's on the responsibility of the legislature to do it. But I think we now have to look at changing the culture of healthcare amongst this population. Because most of these individuals have never been insured before. They don't know how to utilize the system, and they don't know how properly to get preventative care and ongoing care. The Latino population, for example, most Latinos will wait till the absolute last minute. They don't have access to care, they couldn't afford it. Oh, and by the way, I'm completely supportive of healthcare for all. So what do? When it becomes to the point where it's, beyond the point of no return, they end up in the emergency room, the most expensive type of care that we possibly have. Or they self-medicate, especially within the Latino community. They go to Tijuana, they get their medications, they go to the pharmacy, they just kind of self-medicate. But what we have to do is change the culture of those in that population to teach them how to use the healthcare system. You go on a regular basis, you keep your blood sugar under control, you do your A1C, you do your high blood pressure check, you do your prostate, examination, is to change the culture. So the question I have for you and the challenge is, how do you as organizations now reach out to the community to change that culture now that government is implementing this historical act? It's one thing to have access or have a health card. Another thing, you need the access, which we'll work on, but how do you get them to utilize it? So the question is, it's an open question and a challenge.
Okay. Because you have your program.
Well, I think with the passage of the ACA and the Medicaid expansion, Medi-Cal expansion in California, what we're seeing is that there's been a huge disruption to a system that wasn't adequately serving all of the population. It was a system that was designed for a certain segment of the population. And so now that we have all of these new folks coming in, it's exactly what you're saying. Many do not know how to use the system, but then also on the provider side, I think there needs to be some training on that side too. We need to find out, one, we need to go out and do some education, and we have written a proposal. Sarah will probably talk more about this, about how we go out and actually educate people who've never had insurance before on how to use insurance. So we're on that track too. But then we also need to make sure that we're collecting evaluation data, because if they learn and they still don't use it, what's the cause? So we need to, it's not just a one-shot deal. We know, I know Kaiser did a study, they were trying to reduce costs. So they looked at their highest cost center at this one area was the ER. And they saw that there were these people that kept coming in with unmanaged diabetes. And every time they'd come in, they'd end up in the hospital for about a week while they got stabilized and observed. And what they found was that it wasn't that these people didn't know how to medically manage their disease, but it was that life was getting in the way, and there were all these other things that were getting in the way. And so what Kaiser did is they provided them with social workers that would come out and visit with them once a month and connect them to other resources. So I think this issue of use It's a complicated one, and it's one that's going to have to be iterative, where we're going to have to evaluate on both sides, not just the providers on what's working for them, but also on the consumers and what's working for them.
And I agree, we have a strained system, especially with 1/3 of the population now in Medi-Cal, and to me, that's the population that has the greatest need and most of the problems. So I think it needs to be a parallel track of, making sure that network is robust or, efficient and sufficient, and at the same time, educating the population on how to not necessarily use the health insurance, but how to access the health wellness and how to access health care in this. Is there any other thoughts or in what you guys are doing as organizations?
Yeah, so I think you also touch upon the fact that the way that healthcare is going to be delivered is also going to change. So the way that we're now paying for healthcare, it's not necessarily hospital inpatient based, but now people are really shifting to look at quality improvement, value-based purchasing. And so I think that is also where we have an opportunity to say, can you base your quality on reducing health disparities? Can you really look at this population and say, rather than just doing some sort of general colorblind quality self-management program, is to really narrow down, to use that data to be able to look really specifically at those rates, to say, we know that within the Latino community, or we know that within the Filipino community, these are two communities that we need to focus on because they have those highest rates of issues. And so that's where I think in terms of utilizing the data we want to focus on. And I think also in terms of informing, how that shift around value and quality purchasing occurs is, again, trying to provide that lens. We have both reached out with the CMA Foundation and LCHC to do some individual trainings or some kind of town hall meetings to talk about what health insurance is. But there's also a really important group of folks, the navigators, that were helping people utilize the system, who are trained in the system and who potentially need some additional funding or need some additional resources to help then continue to make sure that people are renewing their healthcare coverage, but also that they know how to utilize their healthcare coverage. So that's sort of a population that we can also tap into to make sure that they have the ability to then go that next step in terms of informing people about how to utilize their healthcare.
I think to build on Sarah's point, I think Cover California made an important step in investing in the Community Health Navigators program to help them not only just enroll people into Cover California, but support the organizations that are providing the wraparound services. But the dilemma with that is that, unfortunately, federal funding for the Navigator program will continue to diminish as the years progress. And despite its success, the funding for it continues to be a struggle. But we've seen a successful model for it, right? The Promodoro system within the Latino community, Community Health Navigators within the API community. Those are the programs that not only sign you up for the services that you're eligible for, but actually teach you culturally, in a culturally appropriate manner, how do you actually utilize those services.
Yeah, thank you. Okay, thank you very much. Seeing no other questions, I again appreciate your time for being here this afternoon. We're going to now move on to item number 3, Beyond the Triple Aims. We have 2 individuals that will be speaking. We can have both of them come up. We have Ignatius Bao, Health Policy Consultant, and Howard Berliner, the New School. And welcome. Good afternoon.
Thank you. My name is Ignatius Bao. I'm an independent health policy consultant, and I'm really pleased to be here to try to broaden the conversation. I think the first panel really highlighted the importance of identifying the health disparities that exist here in California. And I want to shift the conversation to what then can the state of California do, not just from the governmental perspective, but precisely from the perspective of all the other stakeholders that provide health care and take care of the community health here in this state. Unfortunately, part of the challenge we have is in the United States and here in California, we still have a very fragmented healthcare system and a public health system that often doesn't work very well with that healthcare system. And so there's different governmental bodies, there are different incentives to move those stakeholders to address something as challenging as health disparities. The good news is that there are examples both at the federal level and in other states in which state governments, but also federal programs are finding opportunities to incorporate the reduction of health disparities into the other work that these health plans, physicians, hospitals, and other healthcare providers are trying to do in the spirit of healthcare reform. And so I want to highlight some of those and suggest that California can learn from those and leverage some of those ongoing activities to actually begin to reduce the health disparities here in this state. The first really does go back to this question of data. And I want to take a slightly different perspective on this, which is not only the importance of collecting this data, but doing it in a standardized way. If a hospital cannot exchange data about a Filipino patient with a physician because the physician has coded that patient as Asian and not as Filipino, then they're not going to be able to communicate with each other about that particular patient. And so part of what we're trying to do, especially in the era of electronic health records, is move to a place in which that information will be electronic, and in our health information exchange, we'll have standardized elements that include the demographic data. And so as California moves to implement a more robust and comprehensive health information exchange here in the state, it can make sure that there's standardization of those demographic data elements. Not just race, ethnicity, and language, which we've heard about, but also sexual orientation, gender identity, and disability, for which there is emerging consensus that these are at least the kinds of demographic data that we should be looking at. Another opportunity that California has right at the present time is as it develops either an all-payer claims database or a cost and quality database that will monitor the claims from the health plan or purchaser side, that again, if demographic data is not standardized and included as a mandatory element of those databases, we miss an opportunity to address disparities. But these are two initiatives that are already taking place, and it's simply making sure that the demographic data standardized is included in these initiatives. And then moving forward, as California continues to implement patient-centered medical homes, as it continues to implement shared savings programs and value-based payment models, and individuals get federal funding and other support to experiment with these new kinds of payments that will drive quality and reduce costs, that again, we already can see from national standards, from the National Quality Forum, from the Joint Commission, from the National Committee for Quality Assurance, and many others, that they have already built into their standards for patient-centered medical homes, for accountable care organizations, for shared savings programs, the identification and the reduction of health disparities. And so if California continues to implement these kinds of initiatives, which I fully expect it will, making sure that the health disparities elements of those initiatives are highlighted and clearly mandated and enforced will help California begin to actually make a difference in reducing health disparities.
Thank you. Please proceed.
Thank you. My name is Howard Berliner, and I'm pleased to be here today to talk about the lessons we've learned from Medicare's now multi-year payment reform programs as they relate to healthcare disparities. Today, I want to focus on one case study, Medicare's hospital readmissions within 30 days penalties, because I think it's the quickest and clearest way to illustrate and to illuminate the problems that occur when a disparities or equities framework is not built into payment reforms that aim to meet the goals of the National Quality Strategy or the Triple Aim. 3 years of data on hospital readmissions penalties teaches us two lessons. One, poor communities lose the most. Not sure this is as clear as it could be, but what we see are that safety net hospitals serving poor, diverse urban communities are the most heavily penalized in the readmissions process. As the chart shows, in 2012, the first year penalties were assessed, 80% of the hospitals in the top quartile, that quartile of hospitals serving the most poor patients, were hit by readmissions penalties, while just over 60% of hospitals in the lowest quartile, those serving the least poor patients, the wealthiest patients, incurred penalties. The most recent penalties in 2014 have the same harmful effect. As Kaiser Health News states, quote, "Safety net hospitals that treat large numbers of low-income patients have been more likely to receive penalties, in part because poor patients face financial and logistical challenges that make them more likely to get sicker after discharges than others," end quote. Thus, if race and ethnicity, linguistic and cultural and other sociodemographic factors upstream from the hospital that play a significant role in its 30-day readmissions are not taken into account, hospitals that serve poor communities of color lose economically. The irony is that the old rationale that better quality results from the readmissions penalty is being called into question by the evidence. And this brings us to lesson 2, that the readmissions penalties are not about quality. This is from a study in Health Affairs looking at California hospitals, found that the Medicare DSH safety net hospitals had better patient outcomes as measured by mortality rates for heart failure, heart attacks, and pneumonia, the penalties for which you incur readmissions penalties, the conditions for which you incur readmission penalties, but suffered greater financial penalties both in readmissions and the other Medicare value-based purchasing programs. As the exhibit shows, safety net hospitals were 30% more likely than all other hospitals to incur readmissions penalties. And if you look towards the middle of that chart where it says hospitals penalized under the HRRP, the Hospital Readmissions Program, you can see what I'm getting at, that 30% difference. But if you analyze these same groups of hospitals, it was the non-safety net group that had worse patient outcomes for all 3 conditions that resulted in readmissions penalties. There was an 18% higher mortality rate for heart failure patients, a 10% higher mortality rate for heart attack patients, and a 3.5% higher mortality rate for pneumonia patients in the hospitals that did not get penalized for readmissions. Because Medicare's hospital readmission program does not take health and healthcare status and disparities of patients and communities into account, its results to date are flawed. The penalties disproportionately hit hospitals serving poor, diverse communities compared to those in better off communities, even though these same safety net hospitals incurred the high readmissions penalties, have better, not worse, patient outcomes than the less penalized hospitals. My written testimony goes into some detail on how and why the federal system of quality measurement developed as it has. It then highlights the turning point federal policy currently faces. The National Quality Forum has broken its longstanding policy of excluding consideration of the socioeconomic and demographic factors that underlie health and healthcare disparities, and is engaged in a 2-year trial period to study how they should be accounted for in quality measures. Congress is involved and last year mandated studies on disparities in quality measures in the IMPACT Act. But meanwhile, Centers for Medicare and Medicaid Services Secretary Burwell recently tripled down on extending Medicare's value-based purchasing programs, setting a goal of 85% of value-based purchasing in 2016 and 90% by 2018. It's not yet clear how all these forces will coalesce in Washington. One advantage states who are engaged in their own payment reforms have is to learn from the federal experience to date. My recommendation to states is to make serious disparities analysis an integral part of payment reform rather than having to play catch-up like the NQF and CMS will have to. States should incorporate an equity or disparities frame into the triple aim from the beginning, and in that way avoid some of the problems that the federal system has run into. Thank you, and I'd be glad to answer any questions you might have.
Thank you. Any members wish to? Assembly-Member Wood? Yes, sir.
Yes.
Okay.
Thank you, Mr. Chair. Just a quick question. You talked about, areas where poorer people were suffering more. Is there any additional data on the populations within those poorer areas, as far as ethnic groups, communities of color? I mean, there something else there, or is it just more, more prosperous areas versus poorer people?
I think you've hit on, if you will, the nub of the problem, which is that we don't really have the data that allows us to look beyond some very gross measures of whether a community is poor or not poor. We don't have the measures in any way built into the way that we understand our health data that would allow us to look at race or ethnicity or other kinds of factors, income, in a way that really would highlight that, except for, the census data, which is what it is.
Any hope that that might happen?
Well, I think the hope is that states will begin to try to attempt to require that data, be present certainly in public programs, if not in private insurance programs, so that we can, in fact, researchers can begin to analyze this on a far more granular level than we've been able to in the past.
Thank you.
See no questions. Yes, Senator Money, sorry.
Thank you, Mr. Chair. This perhaps goes beyond the purview of your study, but hospital readmissions, if either of you have data, there's been some investment in social workers, outreach workers, where you have returning low-income homeless folks getting stabilized in an emergency room, being released, and then they're back 6 weeks later. And by investing in health promoters, more social outreach workers who help them stabilize, medication regimes, find them a place to live, do either of you have any data on the value of that investment, and can it be rewarded or factored into these penalty equations?
Sure. There's been, even before the healthcare reform law was passed in 2010, a lot of work here in California, particularly in emergency departments, of how do we reduce inappropriate emergency department utilization, and similar kinds of programs in other states, New Jersey, other places around the country, finding exactly what you said, which is if you pair up more of a social work, comprehensive approach that isn't just based on meeting their needs and the medical needs in the emergency room, but really stabilizing the rest of their life, which may mean finding them shelter, which may mean finding them a home, as opposed to addressing simply their medical conditions, then you are going to reduce that use. We're also shifting the attention to folks that could avoid a readmission, not from these other kinds of conditions, but simply because they didn't understand their discharge instructions, they didn't have good support systems when they went home to the setting in which they were living. And so there are also lots of programs, including here in California, to improve those transitions of care and to try to avoid and reduce admissions and readmissions that can be preventable.
And are any of those programs eligible for, can they get Medicare or Medi-Cal reimbursement for that investment that's not an immediate emergency room medical cost?
So a lot of these programs, the emergency room kinds of programs, were primarily foundation funded. Externally, a lot of the readmissions and transitions of care programs are currently funded under the Affordable Care Act as pilots and demonstrations. And hopefully these are the kinds of things that then commercial payers as well as Medicare and Medi-Cal will see the cost benefit of actually including them as ongoing ways to reimburse.
Thank you.
Thank you. Yes, Senator Chavez.
Thank you. I'm intrigued about your slide, safety net hospitals, and your comparison of other hospitals. Go down the two numbers for me: acute myocardial infarction 14.5, 5.0, then explain heart failure 9.5, 11.2. What's the good number? What's the bad number?
These are mortality rates, so these are death rates from those conditions.
So
So lower is better.
Lower is a better number. So
Yes.
the safety net hospitals, as you define them, are hospitals that are in impoverished communities, your regional care centers. It's not your La Jolla Scripps or anything. Is that correct?
That's correct.
So I get better care at a That's interesting. The,
To be sure, for these three conditions.
so is it a process issue or is it the quality of the patient that's coming in that's farther along? What do you think it is?
I think in many cases, safety net hospitals are far more used to dealing with a much wider variety of patients who are generally more sick. They have generally larger emergency rooms and more active emergency rooms. And I think they have staffs that are then better able to deal with more complicated patients. They're more used to trying to do that. But the point of this is that they get penalized, you know, from a federal perspective for a policy that, you know, just doesn't work because it doesn't take into account the kinds of patients that are coming in to use them.
So you're getting a better quality care at a safety net hospital than another hospital
Certainly, at least for these three conditions.
for those three conditions?
In California, in 2009 to 2011.
That just doesn't sound right to me. Now listen to it. Let me take, now that's a 2014 slide.
Excuse me, but the data are from 2009 to 2011.
2009 to 2011, thank you. Now with the Affordable Care Act and more people having access to care, assuming that other hospitals, people are probably more affluent, do you think that's a valued assumption? Okay, so if they're more, so with the Affordable Care Act and people have more access to care as in other hospitals in your slide, does that mean then with the Affordable Care Act and more access to medical care that we're going to now see a lower quality of care according to your slide?
I don't see why that would be the case. I mean, what we are seeing through the Affordable Care Act are, you know, lots of people, I mean, it's certainly very true in California, who haven't had insurance before, either, you know, be eligible for Medi-Cal or be eligible for private insurance. You know, in theory, this should help those safety net hospitals that have traditionally seen those patients do better financially. But if you have programs on the federal side which penalize hospitals, you know, for trying to do better, then not sure, you know, how effective that is in keeping those hospitals financially stable.
Something's not right. Okay, thank you.
Thank you very much. A couple comments. I agree with regard to the data. We need to standardize it. I've been working on an all-payers database for numerous years. We've had some select committee hearings on that particular case, reducing healthcare costs. I guess my question would be, who ultimately is going to be responsible for the collection of data? I'm assuming it's at the provider level, but more importantly, at what state agency, and we'll eventually get to them as they get here, is who houses that? Any suggestions or recommendations where that should go?
So I think we want to move into an environment and support an environment in which the data is collected and available electronically through electronic health records. And so some of that is going to be housed at the point of a physician's practice, but some of it is also going to be at the health plan level. And if the person needs hospitalization, then it's also going to be at the hospital level. And so while all those systems currently exist, that health plans, physician practices, and hospitals all have electronic information systems, they don't do a very good job of talking to each other right now. And so it's not simply that they're all going to be housed in one massive data warehouse or clearinghouse, but where the data currently exists needs to be exchangeable, and it's probably going to be through some sort of cloud-based solution rather than them trying to all communicate with each other, that they all can access the same data without actually doing point-to-point communications.
Right. And I think it's important, but I'm only just cautioning my concern, especially on the provider side, with what's being placed on the providers for other additional things that they have to do besides the collection of this particular data. I'll give you an example from ICD-9 to ICD-10. I mean, it's going to be horrible. I mean, I think the provider group that I'm going to have the most sympathy with is going to be the ER docs, because they have to deal from head to toe Whereas, at least in my case, I'm just dealing with the eyes, but it's pretty onerous dealing with the ICD-10. But then to add this on top of that as well, I'm not saying it shouldn't be done, but I'm just trying to figure out the most efficient way how to do it. With regard, I got a question for you, but, with regard to the readmission penalties, obviously that's at the federal level through Medicare, and I believe to Mr. Chavez's comments, I agree that they are more efficient because of the number of instances, the population, and the high comorbidities that they deal with. The analogy would be like, a physician that's dealing on the battlefield with gunshot wounds, they see a lot more of them than, say, a physician out in Beverly Hills who sees very few gunshot wounds. So the number of those types of patients that go through, there's many more of them, so they're better at it. My biggest concern, obviously, is the fact that the federal government's penalizing for the readmission portion because there's so many comorbidities and they're a much unhealthier population. So, two-part question. I mean, do you sense that the federal government's going to eventually change that so it doesn't hurt economically the safety net hospitals? And then the second question is, how is the Medicare readmissions policy played out here in California, and how do we compare to the rest of the country?